So before saying that when I do consider ECMO, I have few facts which I believe and also some philosophical thoughts when I do ECMO. First and foremost is I have to believe ECMO saves life. It looks like a pretty simple statement, but a lot of people don't believe it. And then there's not much of hard data for every disease we put on ECMO. But if you ask to people who are ECMologists or who does ECMO regularly, they know there are times we save the kids with ECMO. So that's the number one fact there. Second one is, that's another one we have to think about. It's more important is not for us to understand, but to tell the families before you put on any child or patient on ECMO that it is not a cure for disease. Pulmonary support, not a long term. So how temporary is another question. Now it's a moving target of few weeks, now almost few months many centers are using. So another one, a moving target for the, shows that early initiation of ECMO in certain conditions, especially if the indications are there, may actually improve outcomes. That's another one. Should not be a final common pathway to death. So every child or every patient who has to die should not die on ECMO. That's another one. So we've got to be careful about it. With this, when do I consider ECMO? First thing is patient should have a serious cardiopulmonary disease with a high risk of mortality. What this means is the mortality with a conventional therapy should be high, and then mortality with ECMO should be low. So these again, the percentages are changing. It depends upon the underlying condition, age, and then also with the changing in our ICU care, the mortality with the conventional therapy is changing. So again, it's a moving target, but that should be the concept of when to place an ECMO, place a child on ECMO. Disease condition should be a reversible or treatable without, and lastly, there should be a failed conventional therapy, either a CPR, if it is a eCPR, or ventilator support, any other of those things. So we should have a failed conventional therapy there. So if you look at the numbers from the ELSO, this is US numbers, the neonatal ECMO is coming down as a percentage, and then pediatric and adult ECMO is increasing. Right now, the congenital diaphragmatic hernia is the commonest as a single cause of placing an ECMO in the US, but the rest of the world is still the mechanism aspiration is becoming the number one there. These are a list of common conditions we place an ECMO. So there's no universally accepted criteria to place, although there are some numbers are there which we are going to present it, but there is a lot of deviations from those so-called criteria there. There is institutional variation in mortality, and ECMO experience in a big centers make those numbers a little more moving target than actually absolute numbers there. So there are a lot of relative contraindication in the past. Now they are placed on ECMO there. So thinking about the gestational age, 34 weeks or less is probably, in our unit is an absolute contraindication. But again, some centers are using once in a while a good candidate less than 34 weeks. If you look at the mortality, early report from Bartlett show that anybody who is less than 35 weeks showed 100% ICH with only 25% survival. But a later report shows less than 35, 40% mortality and 40% ICH. Still big number, major mortality, but still a 60% survival is there. Birth weight, less than 2 kilos, again a contraindication. One of the things is probably cannulation difficulty. In our unit, again, 22 kilos is the cutoff. Occasional 1.9 kilos we discuss with our surgeons and then we place. But cardiac surgery is being performed lower than that. And then many centers are pushing it, depending upon the gestational age, they may be actually doing lower age group. Grade 3 and grade 4 hemorrhage are absolute contraindication. In fact, in our unit, if the grade 3 hemorrhage happens on ECMO, we try to come off, giving some more time and talking to the families. Lethal malformation. This is another area of moving target. We do not place anybody who's, if you have definite diagnosis of trisomy 18, 13, or any other lethal malformation. When we don't know, we suspect but we don't know the diagnosis, we place on ECMO, talk to the family, and we may come off afterwards. But having said, now trisomy 18s are living longer and longer with a conventional management, and then we actually performed cardiac surgery in children with a trisomy 18. So this is another one the variation is there. Trisomy 21, there is no contraindication. In fact, legally we can't refuse ECMO on a trisomy 21. So entry criteria for respiratory disease for the neonates is oxygen index of, A gradient of more than 600 at sea level. But it depends upon, again, what is the neonate looks like. If the child has a gradient of 580, but we have given multiple fluid boluses and the hemodynamic instability, I would place that kid on ECMO rather than a 600 A gradient but stable with a dopamine of only 5. So it really depends on the combination of those factors. Oxygenation index, again, more than 40 for 4 hours, definitely we consider for ECMO. But now there is a data to show that, especially in the neonates, OI of more than 25 and less than 40, they have a better outcome. So in our unit, in our hospital, we do ECMO in the PICU. The NICU patients with the OI of more than 25, they are transferred to the PICU 2 and then watched there for ECMO watch. The other part is the acute deterioration. That's probably more common indication, at least in neonates, with a fluctuating blood pressure and unstable pulmonary hypertension, with a pH low, metabolic acidosis, hypotension, or acute deterioration with oxygenation. Another condition we talk about, the congenital diaphragmatic hernia. Here the entry criteria is all over the place. There's no really validated criteria there. Individual institutions prefer their own ways of doing. We do, first of all, managing the CDH with a gentle ventilation, and then in spite of that, the preductal saturation, not a postductal saturation, of less than 80%, or a PCO2 consistently around 100 in spite of maximum medical therapy, we consider ECMO. Pediatric respiratory failure, acute life-threatening but potentially reversible disease is the indication after a maximal ventilator therapy. If you look at all that statements, everything is vague. So again, there is a lot of vagueness is there when you go on ECMO. It depends upon who is on that day, and then what is the child's condition before coming there. A child with 10 days of ventilation with a high pressure versus 14 days of ventilation with a low pressure may differ. So there is a lot more art there rather than just a scientific numbers there. So again, pediatric ECMO numbers are increasing significantly. More and more children are being placed with an increasing number of centers. A grade more than 450 is the one indication of consideration for ECMO in our unit, same as oxygenation index of 40. These mortality rates are done from the 90s, really very old data. Now I don't think the mortality rate is that high with the same indices. So we need to reconsider when you want to place these kids on ECMO there. Again, persistent hypercarbia with a pH of less than 7, and then also a persistent air leaks, we have to consider placing the children on ECMO there. How long one can ventilate before we say no to ECMO? The number touted in our also red book is about less than 2 years, 10 days versus more than 8 years, 7 days. Now the recent data shows that up to 14 days the mortality is not changed. So again, depending upon how much barotrauma already happened, so we need to look at by individual cases really, rather than just one number. But if it is more than 7 days, we re-look at it and see whether the child really can reverse. Especially a child with RSV bronchiolitis, we probably put a place on ECMO because the probability of the child coming off is much more higher. There are more children with comorbidities are placed on ECMO in recent days, like a renal failure, chronic lung disease, BPD kids with not much on oxygen right now before getting into acute deterioration were contraindicated before. Now we do place them and they come off the ECMO. Same with the cancer immunodeficiency. Now if you look at the big chunk, the other group is a combination of all these numbers there. And then the outcomes are not too bad. If you look at the one example of malignancies, the outcome ECLS survival is of 42% and a hospital discharge of 35%, and children who are placed on ECMO with underlying malignancies. And then about 95% of the ECMO centers say that they do consider these kids being placed on ECMO.